titled Diagnostic Criteria for Connective Tissue Diseases. Introduction. Hello friends, welcome back. Today we're diving into the diagnostic criteria for connective tissue diseases, step by step with real-world examples. We'll cover 6 major sets of international criteria: SLE, systemic sclerosis, dermatomyositis and polymyositis, Sjogren's syndrome, mixed connective tissue disease, and antiphospholipid syndrome. And to make things practical, I'll explain each one with a short case vignette, so you can see exactly how doctors apply these rules in real patients. Let's begin. 1. Systemic lupus erythematosus, ACR-EULAR 2019. To classify lupus, the very first requirement is a positive ANA test. Without ANA, the criteria cannot even start. Then points are assigned to different features, and if the score reaches 10 or more, the patient is classified as lupus. Vignette example. Imagine a 25-year-old woman. She has a photosensitive malar rash. That gives 6 points. She also has arthritis in her hand joints. That's another 6 points. But remember, only the highest item in each domain is counted. So arthritis counts, but not twice. Her blood test shows positive anti-dsDNA antibodies, adding 6 more points, and low complement levels, which adds 4 points. Added up, 16 points. Clearly above the cutoff of 10. This patient would be classified as SLE. Why does this matter? Because lupus is very heterogeneous, and the scoring system helps pick out the cases where multiple clues point in the same direction. 2. Systemic sclerosis, ACR-EULAR 2013. Systemic sclerosis can be recognized by one major feature: skin thickening beyond the MCP joints. If this is present, the diagnosis is made right there. If not, we score different features: Raynaud's, fingertip scars, telangiectasia, abnormal nail fold capillaries, interstitial lung disease, and specific autoantibodies. Vignette example. A middle-aged woman presents with Raynaud's phenomenon. That's 3 points. She has fingertip pitting scars, 3 more points. Capillaroscopy shows abnormal nail fold capillaries, giving 2 points. And finally, she tests positive for anti-centromere antibody, worth 3 points. Her total is 11. Since the cutoff is 9, she fulfills the criteria for systemic sclerosis. This system ensures even patients with limited cutaneous features but positive antibodies are not missed. Dermatomyositis and polymyositis, ENMC and EULAR ACR. Here, both clinical findings and investigations matter. Think of muscle weakness, skin rashes, enzyme levels, MRI, EMG, and sometimes biopsy. Vignette example. A 52-year-old woman comes in with a heliotrope rash around the eyes and Gottron's papules on her knuckles. She complains she cannot comb her hair or climb stairs. Classic proximal muscle weakness. Her CK level is 2,000 units, far above normal. MRI of her thighs shows muscle edema. Together, these features give her a high classification probability for dermatomyositis. Later, antibody testing reveals anti-TIF1 gamma positivity, which alerts us to also screen for malignancy. This case shows why both skin signs and antibody testing are crucial. For Sjogren's syndrome, ACR-EULAR 2016, Sjogren's requires symptoms of dryness and a score of 4 or more based on objective tests. Vignette example. A 60-year-old woman complains of persistent dry eyes and mouth. Her antibody test comes back positive for anti-SSA, which alone gives 3 points. A Schirmer test shows only 3 millimeters of wetting in 5 minutes, adding 1 more point. Her total is 4, exactly at the cutoff. She meets the criteria for primary Sjogren's syndrome. The key here is objectivity. Many people have dry eyes, but when we combine autoantibodies and test results, it becomes much more specific. 5. Mixed connective tissue disease. Alarcon-Segovia criteria MCTD requires high titer anti-U1-RNP antibodies plus at least 3 clinical features: hand swelling, synovitis, myositis, Raynaud's, or sclerodactyly. Vignette example. A 35-year-old patient has Raynaud's phenomenon, swollen puffy hands, and arthritis in several small joints. Her blood test shows a very high titer of anti-U1-RNP antibodies. She has exactly 3 clinical features plus the antibody. That fulfills the Alarcon-Segovia criteria for MCTD. This illustrates how overlap syndromes borrow pieces from lupus, scleroderma, and myositis, all tied together by the anti-U1-RNP antibody. 6. Antiphospholipid syndrome, Sydney 2006 criteria. Here, you need 1 clinical event and 1 lab criterion. The labs must be positive on 2 occasions, at least 12 weeks apart, because transient antibodies can appear after infections. Vignette example. A woman has a history of unprovoked deep vein thrombosis. Later, she suffers a fetal loss at 20 weeks of pregnancy. Her tests are positive for lupus anticoagulant on 2 separate occasions. She meets both the clinical and laboratory criteria. This is antiphospholipid syndrome. It's important to remember that without persistent antibodies, the label cannot be applied. Dr. Yogesh gives closing summary. So friends, let's recap. SLE criteria start with ANA positivity and a point system up to 10. Systemic sclerosis uses skin thickening or a 9-point threshold. Dermatomyositis and polymyositis combine skin, muscle weakness, enzymes, imaging, and antibodies. Sjogren's needs a score of 4 or more with symptoms of dryness. MCTD revolves around anti-U1-RNP plus overlap features. And APS requires both a clinical event and persistent antibodies. These criteria bring structure to what are otherwise very complex diseases. They are not perfect diagnostic rules, but they guide doctors and researchers to recognize patterns, classify patients, and give treatment more confidently.